Hi, Adult Health 1. So this is Module 7B. This is just the second PowerPoint that goes with Module 7. All right, this is Chapter 64, Assessment of Reproductive Function, Female and Male. Chapter 65, Female Reproductive Disorders, and then Chapter 66, Male Reproductive Disorders. This PowerPoint, I suspect, will take less than an hour. There's not a whole lot. There's, we talk about the different cancers related to reproductive disorders, and to be honest, the nursing, actions, assessments, teaching, that's all going to be pretty similar, okay? So we'll identify some of the differences, but for the most part, that stuff is going to be similar. So here is our objectives. All right, so female reproductive parts. So I'm pretty sure you guys went over all this in fundamentals, so I am not spending a whole lot of time dissecting the pieces and parts. If you feel like you're not that familiar, or if you're listening to this or studying and have a question, please go back to the book and look it up and just take a gander, okay? So together, the main goal of the female and male reproductive system is to ensure the survival of the human species through creation of life, right? We're supposed to have the babies and keep the human species going. To accomplish reproduction, the female reproductive system manages the following: secretion of sex hormones, production of an ova, which are the eggs, maintenance of an environment for fertilization, embryonic and fetal development, and expulsion of the fetus. Having a baby, okay? Anatomy of the female reproductive system includes external and internal reproductive organs. So does the male, right? There's all this related to all of that. Female breast tissue consists of glands, lobes, ducts, and fibrous and fatty tissue. Menarche is the first menstrual bleeding. First menses is an indication that the individual has reached puberty, which is preceded by increased production of progesterone and estrogen secreted by the ovaries, right? The sex hormones, okay? So, menstruation just means that you are now old enough to have a baby. Lucky you. Typically occurs between 12 and 13, but can be between the ages of 8 and 16. Ladies, can you imagine being 8 and getting your first period? That'd be horrifying. Also in here it talks about like FSH and LH, hormonal secretions related to the pituitary gland, and how all of that plays into that. This is a slide box 64.1, galactorrhea. I honestly had never heard this, and now this is like the third day in a row I've heard this term. So galactorrhea is the production of milk from the breast that occurs outside of normal lactation. So you're getting milk from the breast, but you didn't just have a baby, right? This can be a sign of underlying pathology and should be evaluated. Galactorrhea usually affects female persons of reproductive age, but has also been seen in males and infants. There are several causes which range from sexual stimulation of the breast, abnormalities in hormone levels, and pituitary adenoma. Galactorrhea can resolve spontaneously, and in some cases, the cause may not be known. The evaluation of galactorrhea usually includes a physical exam, serum hormone testing, and imaging if necessary. Here is a picture. This is a picture of like how the hormone levels fluctuate, how that affects the egg being released, like where in that cycle that is. Sorry, to be honest, I'm reading a text message from my husband, but here we go. Back to this. So this little slide, slide 5, just take a look at that. It also shows you how the uterine lining builds up or decreases as throughout the menstrual cycle and related to the hormones. All right, male reproductive parts. Also internal and external. And then I just like this word, spermatogenesis, process of sperm production. Spermatogenesis. It's pretty good. Assessment of reproductive organs. So we're going to do a complete history, right? We're going to start with that. We're going to talk about allergies, meds, past medical history, surgical history, psych history, family history, and then detailed reproductive history, right? So all of those things. Physical exam of the genitalia consists of external and internal, and then also a breast exam on both males and females. Diagnostic studies, we may do imaging, there can be surgical procedures, lab assessments, right? For women, there's pap screening. They can use wet preparations, you know, if they do a swab and want to look at something. You know, you can do swabs of cervix, vagina, rectal, genital, any of that. So any of those things, you know, we can take a look at. Table 64.1 talks about what is included in a detailed reproductive history. That gets into that whole like GRAVA, whatever, all of those terms related to having a baby. We're not there yet. Okay, you guys can put off learning that until you are actually in OB. That is okay. Like Gravida, Para 1, and all of that stuff. You can ignore that for now. Table 64.2 is a list of drugs that can affect reproduction. So those are kind of good to take a look at. All right. Also, let's see, the table on page 1588 is of different diagnostics. You don't have to put it to memory, but you know, just be a little familiar. This slide here, slide 8, straight out of the book, but it's female reproductive health questions. All right. So obviously general reproductive history, menstrual history, pregnancy history, and then sexual history. So take a look at those because those are questions that we don't see related to anything else. You know, a lot of times when we're talking system assessment, you know, we have similar questions. There's similar questions for the heart, liver, kidneys, you know, similar stuff. This is totally different. So definitely take a look at this. Here are the male reproductive health questions, same topics, a little bit different. Table 64.2, this is slide 10. These are the drugs affecting reproduction. Take a look at that. Because we want to be aware when our person is telling us what meds they're on, is this something we're concerned with or not, right? These are birth control options. So slide 11, birth control options. Really, we want to look at the advantages and disadvantages of this, right? You know, like even progestin only pills, birth control pills, like the problem with the pills is they have to be taken every day at about the same time every day, right? And that can be difficult sometimes. You got to carry them with you. Maybe you spend the night somewhere. You know, it's a whole thing. The vaginal ring, you know, we worry about risk of blood clot formation. Then, of course, there's diaphragms and all of that. On the next slide, on slide 2, we have intrauterine devices. You know, those come with their own sets of problems, patches. All of that stuff is hormonal, has hormonal aspects to it, which always runs risks. The implantation, the little rods, you know, looks like a matchstick basically that they implant, also hormonal, you know, causes irregular bleeding. There's injectables. Now, at the very, very bottom, we have a condom for the guys. One thing. So there you go. So that's it. Rest of it, all up to us girls. Slide 13. So this is a safety alert. It talks about before making a decision about which birth control to optimize or to utilize, it is important to understand the safety risks and efficacy associated with all methods. That includes understanding the effect of personal health history, such as history of blood clots, cancer, and/or age that may affect the risk of complications associated with the chosen birth control option. All right, so slide 14, moving on to female reproductive and breast disorders. This is chapter 65. All right, so cancer, we're talking about breast cancer here. So cancer of the breast almost exclusively occurs in females. It affects tens of thousands of patients in the US yearly. Survival rates have increased significantly. Part of that is related to treatment, and part of that is screening, and we find it earlier, right? Before it has metastasized. As an individual ages, the risk of breast cancer increases. Let's see. Ethnicity modifies the effect of age, although ethnicity alone does not have consistent risk elevation. The Black population younger than 50 years of age has a higher risk of developing this cancer, whereas Black population older than 50 years has a lower risk than the white population. So breast cancer can be divided into a series of categories or stages. Those are, of course, related to size, spread to lymph nodes, distance spread to the breast tumor, to other tissues, related to metastasis. Clinical manifestations going to vary depending on the type and the size of breast cancer. Basically, usually like a new mass or lump is noted. Cancer masses are typically hard, irregular, and painless, but they can be soft or rounded and tender, right? It just depends. People can see changes in the shape of the breast or swelling. You can have skin changes like peeling, flaking, pitting, dimpling, or redness. You can have thickening of the tissue or drainage. Diagnostics, we have the mammography, ultrasonography, MRI. They can go in and do a biopsy if they identify something irregular. Medical and surgical management varies depending on the category and stage of the cancer. Treatment options, is cancer, so surgery, chemo, radiation. There is targeted therapy, immunotherapy, and endocrine therapy. Surgery alternatives are breast conservation therapy, also referred to as lumpectomy or total mastectomy. So the difference there is taking the lump versus taking the whole breast, right? Page 1601 of your textbook has a medication table. So complications, treatment does sometimes have complications. Immediate post-op complications are they're the same for any surgery. Wound infection is always a thing. Dehiscence. A lot of times people will have drains in place. There can be complications related to your drains. PE, pneumonia, all of that stuff, right? Long-term complaints, shoulder immobility, pain, lymphedema. Lymphedema occurs because of the removal of axillary lymph nodes and subsequent scarring, resulting in disruption of lymph drainage from the arm. So the result is swelling of the arm. Sentinel lymph node evaluation and minimization of lymph node dissection have led to lower incidences of lymphedema. So again, we're making progress and it's helping outcomes. Once chemo has begun, so there's lots of side effects related to chemo, right? Most common chemo side effects are hair loss, nausea, vomiting, mouth pain, diarrhea or constipation, peripheral neuropathy, rash, and nail changes, decreased WBCs with possible subsequent fever, and increased risk for infection is also a complication. So, those treatments, not fun for anybody, and they take a lot of commitment from whoever the caregiver is to help with all of that, right? So, slide 16 talks about the genetic connection. So this talks about genetic testing to assess for breast cancer. feel free to take a look at this. It talks about the BRCA genes and what family risk factors can be related to, right? Like personal or family history of bilateral breast cancer, what kind of things we care about. RN considerations related to breast cancer, pain and discomfort, right? It's not good, because if they have surgery, there's going to be pain. There could be scarring. Radiation causes burns, irritation of the skin. We have risk for infection. There's usually a lot of nutrition problems, malnutrition because of nausea, vomiting. Just don't feel very well. And then don't forget the whole aspect of psychosocial, body image disturbance, possibly loss of breast. And then if they're on chemo, possibly loss of hair. Hair can be a defining characteristic for some women. And it just, that can be very difficult to deal with. Assessments, obviously vitals, pains, daily weights. Drastic weight loss can indicate a severe nutritional deficit. I's and O's, wound evaluation, skin evaluation. Our person is at increased risk for infection. So we want to make sure that if they're getting radiation, keeping that skin as intact as we can. And then of course labs like CBCs and whatnot. We're going to want to look for nonverbal cues, because maybe our person doesn't really want to talk about it. So we're really going to use our nonverbal cues and our nurse training to try to identify problems, right? Maybe things that we can help with. Actions, we're going to give meds as ordered. Antiemetics. Cough and deep breathe, because we don't need pneumonia. Keeping the wound clean and dry, all of that stuff. Teaching, we're going to talk about the treatment course, meds and treatment side effects, wound care, nutritional counseling, support groups, and then breast cancer screening, right? We're going to want to, if maybe it was just a scare, but we're going to want to talk about breast cancer screening. Let's see, and then that's pretty much it. That's good. Dysmenorrhea. So dysmenorrhea just refers to difficult monthly menses, most common in younger menstruating patients. It is the leading cause of school and work absence in young menstruating patients. So it's usually associated with a normal menstrual cycle with no pelvic pathology. So dysmenorrhea, less common in the first few years after menarche, but becomes more commonplace as regular cycles are established. Severity of symptoms tends to be worse in those early in menarche, or those with longer menses or heavier. Cigarette smoking can increase dysmenorrhea, likely because of nicotine-related vasoconstriction. Right? Only about 10% is related to pelvic pathology such as endometriosis, and then the dysmenorrhea would be considered secondary. Your real sign and symptom is going to be abdominal cramping, but other signs can be like headache, nausea, vomiting. Generally continue for about 24 to 48 hours, and they are going to occur cyclically with the menstruation. Treatment, really we use meds, in particular NSAIDs, right? And they can also do non-med stuff like heat therapy, physical activity, TENS treatments, which work on the nerve stimulation. You may do dietary supplements as well, and then acupressure, acupuncture. With dysmenorrhea, our priority problem really is going to be the pain. Right? The acute pain. Assessments, vitals, pain, actions, providing non-pharm interventions, if they're taking NSAIDs already, You can do cold therapy, heat therapy, any sort of relaxation stuff is going to help. You know, if it's bad enough, they may recommend something like hormone therapies, and a lot of time this is like a PO contraceptive, actually, because it gives it uses estrogen and or progesterone. So a lot of times that can help, believe it or not. Teaching is just going to be related to non-pharm interventions, watching your NSAID intake, potential for hormone therapy. And then always when we're talking to women, we recommend keeping a menstrual calendar. So this is going to track the cycle and it's going to track your signs and symptoms. It can also track, it's a good idea, keep in mind what works for you to help with the situation. All right, endometriosis. So endometriosis results when uterine endometrial glands exist and grow outside the uterine cavity or endometrium, often resulting in pain. Endometriosis is the most common cause of secondary dysmenorrhea. There is an apparent hereditary link to endometriosis. Endometriosis development depends on abnormal hormonal activity associated with the interaction of the enzyme aromatase, an enzyme involved in the synthesis of estrogen. So basically, the endometrial tissue is found outside the uterus, implanted on other body structures. This, from what I have heard, can be very, very painful. The ovaries are the most likely site for implants, but you can have sites in the pelvis, pelvic peritoneum. They call it the cul-de-sac, or the pelvic peritoneum is the cul-de-sac, a pouch between the rectum and uterus. I've never heard it called that. Uterosacral ligaments, pelvic lymph nodes, cervix, uterus, vagina, vulva, colon, and appendix. Less likely, but also possible, umbilicus, surgical scars, bladder, kidney, lungs, and extremities. So signs and symptoms are inflammation and pain. They can be cyclical, you know, with the menstrual cycle, but also acyclical. So typical symptoms include dysmenorrhea, excessive bleeding during menses, pain during intercourse, and infertility. Diagnosis is through laparoscopy with biopsy, and elimination of suspicious lesions. A CT scan, ultrasound, and MRI may also be used in the diagnostic process. Diagnosis cannot be confirmed without surgical biopsy of the endometriotic lesions. They have to make sure those are endometriotic lesions. There we go. You know, because it could be something else. So, but biopsy, you have to have the biopsy for diagnosis. Treatment, hormone suppression through oral contraceptives and progestins are the first line of treatment. If these fail, there's other pharm approaches. Most common, let's see, the most common is surgical treatment though for endometriosis, and this gives patients 5 times the relief that just trying to use meds does. So really, usually, you know, when we talk about surgery, it's our last thing that we try because it's invasive. But because patients get up to 5 times more relief immediately related to surgical intervention than taking meds, surgery is often the first choice. Priority problems, obviously pain, right? Pain is huge. Assessment, we're going to assess the pain. Vitals, let's see, actions, pain medications, maybe GnRH agonist, possibly those are gonadotropin releasing hormone agonist. Those lead to a hypoestrogenic state and therefore decreased symptoms, okay? Teaching, we're going to talk about the disease process, managing the pain, managing everything that goes along with it. Education is going to be related to med use. Any patient receiving GnRH agonists should take adequate calcium and vitamin D for bone protection because it does suppress the estrogen. So then we worry about osteoporosis. And then, of course, maintain that menstrual diary. Menopause. So menopause is considered to have occurred after 12 months of no vaginal bleeding or amenorrhea. So no menses anymore. Okay. All female individuals will eventually go through menopause as they age. On average, menopause begins at about 50 to 51 years. Surgical menopause occurs immediately at any age when the ovaries are surgically removed. So menses are dependent on estrogen and progesterone production from the ovaries. Menopause occurs when ovarian function declines and their estrogen production decreases. If the ovaries do not produce estrogen through the process of ovulation, menses slowly become irregular and finally disappear completely, while the uterine lining becomes thin and atrophic. Signs and symptoms. So box 65.1, these can be, they're vasomotor, right? So it's hot flashes. Also, on top of the vasomotor things, you can have bone loss, osteoporosis, which puts you at increased fracture risk, central weight gain leading to cardiovascular disease, dyslipidemia, and type 2 diabetes. So diagnosis of menopause is typically based on symptoms as described above, and then menstrual evaluation. It is important to rule out other etiologies for amenorrhea, such as hypothyroidism, as it can result in many of the same symptoms as menopause. So treatment, we're going to do estrogen therapy, which is most effective. The problem with estrogen therapy is you increase your risk of breast cancer. So choosing to do estrogen therapy, you need to assess your familial risk for breast cancer. Let's see. All right. They can use estrogen and progesterone combined. And the progesterone helps decrease that risk of breast cancer. Nursing diagnosis or nursing considerations related to menopause. So your patient might be fatigued related to sleep disturbances. Sleep disturbances are related to just having sleep disturbances, insomnia, but also because of the hot flashes and the other signs and symptoms. They don't stop just because you're trying to sleep. There's also impaired memory associated with estrogen loss, and then sexual dysfunction associated with vaginal atrophy. So our assessments, we're going to start with vitals. We're going to be concerned with hypertension because that is a sign of cardiovascular disease. Hopefully our person is keeping a menstrual calendar so we can tell like how often they've been having periods, when their last one was. We're going to monitor weight. It's not uncommon to put on weight during menopause. And then lab review. We're going to look at those hormones like FSH. I don't know why that's so hard for me. Also thyroid stimulating hormone, the TSH, prolactin, do a CBC, see what's going on with the thyroid, all of that stuff. Actions, administer meds as ordered. Other therapies, people may go on SSRIs, gabapentin, clonidine, whatever they can help, whatever helps. Put your patient on it, right? Why not? SSRIs are thought to be effective because they play a role in regulating body temperature. So, on top of helping with mood and all of that, there's other functions that those psych meds play in helping to regulate those vasomotor signs and symptoms. You may want to talk about cooling therapies related to hot flashes, napping related to sleepless nights, and reassurance that symptoms are usually self-limiting. So eventually they go away, eventually. Teaching pros and cons of hormone therapy, right? There's just a lot of things to consider, especially related to that breast cancer risk. Teaching related to etiology of symptoms, that helps in trying to find something that can help mitigate those signs and symptoms. And then there may be sexual dysfunction. So what are the options related to that? And that's, lubricants and some medications and all of that. And then because osteoporosis comes in, we want to talk about calcium, vitamin D, and weight-bearing exercises. All right, fibroids. So fibroids are reported to occur in as many as 70 to 80% of females by the age of 50. They are more prevalent in Black female populations. Fibroids are the most common solid benign tumor of the female pelvis and are the leading cause of hysterectomy. Tumors originate from the muscular tissue of the uterus, but their etiology is not completely understood. Signs and symptoms: many fibroids are completely asymptomatic. The most common symptoms are uterine bleeding and pelvic pressure. Patients may experience heavy menses associated with an overall increase in uterine and endometrial size, or they may experience menorrhagia, prolonged irregular bleeding, associated with endometrial distortion from submucosal fibroids. This is the most common complaint because it often results in significant anemia. Significant pelvic pressure and bulk can result in dyspareunia, painful intercourse, dysuria, and difficult defecation. Because remember, those fibroids can be in there pushing on things, right? And we only have so much space. So it can they can push up against the urethra, they can push up against the rectum, making all of that difficult. Diagnosis of fibroids is often suspected when a patient presents for menorrhagia or pressure symptoms. Pelvic mass may be felt, but imaging is key in the diagnosis. Transabdominal or transvaginal ultrasound is 90 to 100% sensitive in the detection of fibroids. Color Doppler studies help identify the vascularity of the fibroid. I'm still burping my Monster drink from earlier. You're welcome. Medical treatment of fibroids is primarily focused on hormone therapy for reduction of symptoms. Estrogen and progestin combination pills and progestin-only formulas are used to control bleeding and dysmenorrhea. However, evidence suggests that relief in fibroid patients tends to be short-term. Also, there is some concern that hormonal use could stimulate fibroid growth and should be monitored closely if used. This is another one where surgical option is our primary tool utilized in the management of fibroids. So we're going to go straight to surgery for this. Now the thing is, though, if you end up with a hysterectomy, surgical removal of the uterus, you can't have kids. So that's going to come in as a conversation because maybe you're still a young woman, maybe you and your partner are just now talking about starting a family. So that becomes a bigger conversation depending upon your fertility goals. Nursing diagnosis and problem list. So risk for activity intolerance due to anemia, uterine bleeding, and pelvic pressure. Impaired urinary elimination due to pressure from fibroids. Chronic pain related to that pelvic pressure, and acute pain related to the surgical procedure. Assessments, we're going to look at vitals, obviously. Don't forget that pain can cause tachycardia. We're going to talk about the pain scale. So related to this, we're going to talk about pad count. What that means is when you have vaginal bleeding, how many pads or tampons are you going through? How often do you have to change those pads or tampons, right? If you've ever shopped for pads or tampons, there's heavy pads, there's light pads, same for tampons. So are you always having to use the heavy version of things? Are you changing frequently, like hourly? So when we say pad count, that's what that's referring to. Actions. This person may need a blood transfusion, so then we're going to do all the things related to that. Administer non-surgical methods of treatment if chosen. So those are our hormone therapies. They're going to have pain meds likely. Teaching treatment options, we're going to talk about that. And again, that the biggest conversation related to that is fertility desires. How old is the patient and what are their plans for their future related to kids? All right, ovarian cancer. Ovarian cancer is the 5th most common cancer found in females. Approximately 70 to 75% of the cases are not discovered until the late stages. So as a result, ovarian cancer causes the most deaths of any gynecological malignancy. If diagnosed in stage 1, the 5-year survival rate is more than 73%. However, if diagnosed in stage 3 or 4, the 5-year survival rate falls to 21% and then less than 5% respectively. So signs and symptoms experienced before diagnosis of ovarian cancer tend to be vague and nonspecific. Symptoms that should cause one to consider ovarian cancer are bloating, pelvic or abdominal pain, problems with eating, urinary urgency or frequency. In later stage of ovarian cancer, people can have ascites or excessive fluid in the abdominal cavity. So definitive diagnosis is made through surgical removal of a suspected mass, followed by total specimen pathology. Surgical management of a suspected ovarian carcinoma traditionally consists of surgical staging and debulking of the tumor. The debulking procedure attempts to remove as much of the tumor bulk as possible. In addition to removal of the mass, the staging procedure includes peritoneal washings, which is a saline solution is rinsed into the abdomen and pelvis and then removed and sent for cytology. Peritoneal biopsies, removal of samples of the peritoneal enclosure of the abdomen for pathology. All these options here, right? Most procedures also include removal of the uterus, both ovaries and fallopian tubes. So total hysterectomy is what that is called. However, in rare situations where the patient wishes to retain their fertility with very early stage malignancy, total hysterectomy may be deferred and only the involved ovary removed. Medical management with chemotherapy follows surgical debulking. Uterine cancer, so most commonly originates in the uterine lining or endometrium. Uterine cancer originating in the muscular layer is termed sarcoma and is much less common. Signs and symptoms of endometrial carcinoma is uterine bleeding. Postmenopausal individuals with uterine bleeding and premenopausal individuals with irregular or heavy bleeding who have been unresponsive to medical treatment should undergo evaluation for endometrial carcinoma. There is a lot of vocabulary in this one. A lot of vocabulary that I don't use very often. Treatment. So initial treatment, surgical removal of the uterus, fallopian tubes, and ovaries. Adjuvant therapy, so this is therapy after surgery, is determined on the basis of staging or risk. So typically radiation treatment is the choice of therapy, chemo, first-line management for those with high risk or higher stage disease, but response honestly continues to be modest related to that. Cervical cancer. So previously, it was really one of the most common causes of death in the U.S. However, this has really dropped because of Pap smear screening. So, I mean, not only is that good to know, but it tells you how important, all these screening tools are. So nearly 100% of cervical cancer tests are positive in individuals with certain high-risk subtypes of the infectious HPV. Although patients may be infected with HPV and never develop cervical cancer, the high-risk subtypes are almost always the cause of cervical cancer. And we talked about that in the previous PowerPoint, right? So signs and symptoms of cervical cancer, you know what? Really no recognizable symptoms. First of all, not visible to the eye. So it's not like you can look down there and see something that looks abnormal. Vaginal bleeding is probably the most common symptom of invasive cervical cancer. And if you are sexually active, you may have bleeding after sex. If you're not sexually active, it is not uncommon to be completely asymptomatic until the disease is very advanced. Diagnostics, pap smears, right? Routine screening. So we always want to encourage people to go for their pap smears. Treatment, it's a cancer, so surgical management, really biopsies. They can do a radical trachelectomy, which is removal of the uterine cervix only. And this is related to patients who want to maintain their fertility. Again, anytime we're talking about these things with women, fertility always comes into play, right? Where are you with wanting to have kids? Let's see, with a radical hysterectomy, they may do a lymph node dissection depending on the stage of the disease. We want to see if it's traveled or getting ready to travel. Medical management, obviously chemoradiation, that is routine with higher stage diseases. In chemoradiation, chemotherapy is administered at the same time as radiation because it is thought that the chemotherapy makes the cancer cells more susceptible or sensitive to the radiation. This slide 29, this talks about pap smear screening guidelines. So take a look at this, okay? This is straight out of the book. Again, slide 29. This is a safety alert. So this talks about it is important to counsel patients to avoid modifiable risk factors for HPV. This includes early sexual activity, multiple partners, smoking, douching, or poor nutrition. Don't forget with douching, douching changes the pH of the vagina. And the pH of the vagina is higher than the pH of anywhere else in the body because the vagina knows it has to deal with a lot of things, right? So that pH it's more acidy. So it's more acidy, so more things die. So with douching though, you inactivate that high acidic level, okay? Which then actually douching's supposed to be cleansing and whatever, but what it does is put you at greater risk for stuff like HPV, okay? So that could be a very big point of education for people. This slide also talks about the HPV vaccine. And again, go back and review those recommendations if you haven't already. So RN considerations related to cancers. First of all, we're going to think about coping skills, right? Psychosocial, coping, all of that. And then we have acute pain. It can be related to the disease disorder itself or the pain, altered nutrition, assessments. We're going to look at symptoms, vitals, think about our vitals related to pain, right? BP can be up, tachycardia, all of that stuff. Elevated temperature could indicate infection. That's no good. We're going to talk about abdominal girth. My best friend actually had fibroids, and she is this skinny little 5'2" lady, and she had a belly, and she does not eat things or drink things that would warrant having a belly. And no matter what she did, she could not get rid. She did Pilates, what is it, hot Pilates or whatever they call it. I mean, all the things, and she could not get rid of this little pooch. And it turned out it was because of fibroids. So they will either measure abdominal girth or talk to you about abdominal girth, right? Because that can be a sign that something is going on in there. And also manifestations of later stage like ovarian cancers is ascites. So you also end up with that little pooch. A lot of times this stuff looks like Winnie the Pooh. You know how Winnie the Pooh's little belly just sticks out? That is what ascites looks like. Weight loss can be associated with nutritional deficits. We're going to do diagnostic tests and any education related to that. And then, of course, if they're on chemo, we're going to talk to them about the side effects and think about the psychosocial aspects of that as well. So actions: give pain meds, any meds as ordered, antiemetics, teaching, signs and symptoms of reproductive cancers. You know, a lot of times these signs and symptoms are pretty vague. So really women need to learn to communicate anything that's out of the norm, right? Anything at all, you know, bring it up. It certainly doesn't hurt. And then we're going to want to provide information on support groups or counselors, especially if we are dealing with a cancer with a poor prognosis. You know, it helps to talk to somebody. It helps to talk to people who have a greater understanding of what you're going through. This is slide 32. So this is talking about transgender male patients and gynecological care. All right. So, you know, there's a lot of talk about transgender individuals, and, you know, we talk about which pronouns they would like to be addressed as, and that is a very important conversation. But as medical professionals, we cannot forget that we also have to consider that whichever sex they were born as, they may still have reproductive considerations related to the sex they were born as, even if they no longer A, identify that way, or B, are starting treatments to, you know, fully transition, right? Because there's surgical stuff that can be done, but there still remains reproductive considerations related to that sex at birth. So, and that can be a hard conversation, right? So this safety alert just talks about it is important for transgender male patients to receive appropriate gynecological care and recommended preventive screening examinations. So this would be breast, pap, and pelvic exams. Transgender male patients continue to be at risk for gynecological disorders, but often delay seeking this care. Increased sensitivity and knowledge by the medical staff and nurses to the unique needs and concerns of this population can aid in providing these services. So again, it's up to us to have hard conversations sometimes, right? And we always think about, you know, the risk of offending a patient, but at the same time, we need to come from an aspect of care and safety, right? So it just may be a conversation, and I will tell you that as nurses, we are often the ones starting these conversations. A lot of times stuff needs to have follow-up with a physician, but people feel more comfortable with nurses just in general, and so a lot of times it's often us having these talks. All right, slide 33, male reproductive and breast disorders. All right, so we're going to start with BPH, which is benign prostatic hyperplasia. I'm going to say out of all of these, the BPH is the one you're going to have to deal with the most related to males, just in general. So BPH is an enlarged prostate. It's noted in about 50% of males who are 51 to 60, and then 90% of males who are over the age of 80. So 50%, 51 to 60. I always say when you are dealing with a male 65 or older, assume they have the beginnings, at least the beginnings of BPH, all right? This really comes into play, to be honest with you, when we are talking about straight cathing a person. And if we have somebody with renal dysfunction and we are really tracking those I's and O's, if our person cannot urinate, that's going to be a problem, okay? So BPH is definitely something that comes into play frequently, And again, when you have a male over 65, assume there's going to be some dysfunction there. It equally affects male individuals of all races. It's not a form of cancer, okay? So BPH, somebody can have BPH and also have prostate cancer, either together or independently of each other. So the prostate gland is a normal part of the male anatomy. It's about the size of a walnut and it surrounds the urethra. Its primary function is to assist in controlling urine flow. It also mixes sperm with prostatic fluid and seminal fluid to be ejaculated during organism. Around the age of 25, the prostate begins to grow. This growth is not completely understood. When this gland does become enlarged, it pinches the urethra, interfering with the flow of urine from the bladder. So if you have me in class, I'll do this demonstration again, but think about the prostate as a donut and the urethra passes through the center. What happens is the prostate starts to inflame, right? And it squashes down on that urethra. So that's why the individual ends up with urination problems, because that urethra is being squashed by the inflamed prostate, okay? So clinical manifestations of BPH are related to lower urinary tract symptoms. You're going to want to know this. LUTS, lower urinary tract symptoms. These manifestations include difficulty starting the flow of urine, even with straining, a weak stream of urine, multiple interruptions during urination, so like starting, stopping, and then dribbling once urination is complete. Symptoms related to changes in the bladder. Also be aware of this. Urgency, frequency, the feeling that the bladder has not completely emptied after urination, and frequent awakening at night to urinate. As the bladder becomes more sensitive to the retention of urine, incontinence may result. The patient may experience bedwetting and the inability to respond quickly enough to the need to urinate. A urethral obstruction or enlarged prostate that is left untreated may result in bladder outlet obstruction, which includes acute urinary retention, bladder infection, bladder stones, and increasing pressure in the kidney, possibly resulting in hydronephrosis or postrenal AKI, or pyelonephritis, right? And pyelonephritis, remember, is when that UTI travels to the kidneys. Diagnosis is made on the basis of symptoms. It is confirmed with a digital rectal exam. The enlarged prostate can be palpated on examination. A urinalysis is done to rule out the presence of an infection causing symptoms. In addition, the prostate-specific antigen, PSA, level is checked. So PSA is a protein produced by the prostate gland and may be considered a tumor marker. An elevated PSA may be indicative of prostate cancer. However, raised PSA levels may also be due to infection and/or enlarged prostate. So it is important to note that PSA levels do not distinguish between cancer and BPH. All right, so we expect PSA to be elevated with BPH. PSA can also be elevated with cancer. PSA just tells us, elevated PSA just tells us to start looking for these two things. Also, you can have these things and not have elevated PSA. So we use PSA as a marker, but it's not a great marker, right? It's kind of like our ESR and CRP, where they tell us we have inflammation, but they really don't give us any other info, right? You know, they just start us in one direction. PSA is similar. It just starts us thinking something's up. So treatment for BPH. This is very specific to BPH. It's called watchful waiting. It's basically active surveillance. So if you're like starting with BPH, but it's not really affecting your life and you're still peeing appropriately, you know, watchful waiting. Basically, we are going to track your symptoms. Let me know when they get more severe. You know, we're just going to watch it. Just see what happens. So that's watchful waiting. All right. It is advised during this watchful waiting or active surveillance period that the patient avoid tranquilizers and over-the-counter meds that contain decongestants, because these meds can worsen obstructive symptoms. So that's important to remember. That's a huge education piece right there, right? In addition, patients should avoid excessive fluids in the evening to decrease the chances of nocturia, waking up to void. Especially remember, BPH is affecting our older men. So we already kind of worry about falls and stuff like that. And then if you're up going to the restroom frequently during the night, my biggest worry is a fall. Okay, so anything that we can do to reduce that risk of fall is good. So there's lots of meds that they can use to treat BPH. Two of the major classes are 5-alpha reductase inhibitors and then alpha adrenergic blockers. It's not possible to predict which is going to work best for which patient, which is super interesting. However, these meds appear to improve symptoms in 35 to 40% of men taking them. This just talks about the meds. It takes a little while to work and to see symptom improvement. Adverse effects can include headache, nasal congestion, dizziness, drowsiness, postural hypotension, reflex tachycardia, and retrograde or a delayed ejaculation. So those are some pretty serious things that we need our person to be aware of. Other classes of meds in the 5-alpha reductase inhibitors, which act as anti-androgens. So testosterone affects prostate growth and development. So this testosterone then converts into DHT, and DHT stimulates growth factors that encourage prostate hyperplasia while concurrently reducing the rate of cell death in the prostate. So this is what they think kind of contributes to the enlargement of the prostate. You don't have to memorize any of that. But they can use meds that kind of helps shrink the tissues, right? If the patient has BPH, if they have an overactive bladder, you can use anticholinergics to relax smooth muscle in the bladder. All right, so anticholinergics are going to relax smooth muscle in the bladder. Oxybutynin is the one you'll probably see most often. Other alternatives, so they talk about saw palmetto. Honestly, when I was in school and what we learned and what my experience has been, is that urologists actually recommend saw palmetto from the get-go. I've had this conversation with my brother, I've had this conversation with friends, but you turned 50 and you should start taking something with saw palmetto in it. There's lots of options out there, lots of different ones, but it's very, it has, our book kind of, it's surprising me honestly how much our book dismisses the saw palmetto and other supplements, because there really is a lot of research related to especially the saw palmetto and how effective it is. But you got to start it early. Once you start to have problems, saw palmetto is not going to help you. It's a preventative, okay? So you need to start it early, turn 50, start saw palmetto. You're welcome. All right, this is table 66.2. This is talking about some of the meds related to BPH. This has this 5-alpha reductase inhibitor and the alpha adrenergic blockers on there. I cut those out on purpose. Take a look at those. All right, that was slide 35. All right, surgical options for BPH. So surgical options, once we are having BPH signs and symptoms, a TURP is one of the options that we used to hear a lot about. They are actually kind of getting away from TURPs, but there, with my clinical group, there was just a TURP on the floor the other day, so it is still a thing. So TURP is a transurethral resection of the prostate. What they literally do, we have our donut, right? It's squashing my urethra. What they do is they go in and they slice away the part of the prostate that is squashing that urethra. Okay, so from a nursing perspective, your patient's going to be on CBI afterwards, continuous bladder irrigation. There is a video in ATI that talks about CBI. So I did include a slide in here. Please watch that video. It's going to help you understand CBI if you've never dealt with it. You insert a 3-way catheter. Obviously, the 2 ports are the normal catheter. The third port is for irrigation. Our worry is that after the TURP, we can have clotting. And clotting, of course, can lead to an obstruction. So CBI is there to help reduce clots. Directly after a TURP, your output is going to be bright red, and then we expect that to turn pink. Okay, because that bleeding should subside. So with CBI, you expect to see bright red blood initially, expect to see clotting initially, but it's usually about like what, I say it's about what, like I'm not telling you guys. It's usually CBI like 3 to 4 days, maybe. I'm thinking tops, but that output should definitely turn pink, all right? So as nurses, that's really what our concern is going to be. Also, with a TURP, because I'm removing the part of the prostate that is squashing that urethra, people should get relief from symptoms almost immediately, right? They're going to have a stronger flow of urine. There should be no hesitancy. All of that stuff should resolve right after surgery, okay? So that's one of the other things we're going to be looking at. Also, they keep that Foley in place because it's going to be draining the bladder, and that's going to help everything kind of heal before we put the pressure back in, right? Also, because TURP is a surgical procedure, you know, we're going to think infection, potentially. We're just going to look for those signs or symptoms. And then afterwards, a patient is only permitted light activity for a few days, right? Just take it down a notch. Another thing, and honestly, our book talks about these therapies as being like not quite on the regular yet, but these are the therapies I've heard of people using most often these days. So the first one is water-induced thermotherapy. This is super crazy, but it's about a 45-minute procedure. They use a topical anesthetic. Hot water is used to cause coagulation necrosis of the prostate tissue that is compressing the urethra. So then transurethra, so it causes necrosis. So basically it dies, right? It dies, and therefore stops squashing it, right? So then transurethral ethanol ablation of the prostate involves injection of ethanol into arterioles, so tiny arteries and venules, and the ethanol creates a necrotic area secondary to thrombotic occlusion. So this necrosis stops the hyperplastic overgrowth of prostatic tissue. Additionally, additional evaluation is needed for these 2 procedures. Again, these are what I've heard of urologists using. And so those 2, they do the same thing. They go in and kill off the BPH tissue that is surrounding the urethra. So it dies. It's no longer squashing. It's no longer growing. Done and done. Nursing considerations. So our person may have nocturia, so sleep disturbances. Risk for infection related to urinary stasis. Anytime you're not peeing out all your urine, you run the risk of infection. So that could be pyelonephritis up to the kidneys, UTI, anything like that. And then of course increased fall, because if you have urgency and you're like, oh my gosh, I got to go to the bathroom now, or you're waking up in the middle of the night, you increase your falls. Assessments, your urinary symptoms, right? This is going to be subjective. We're going to ask about nocturia. We're going to ask about, like, how do you feel after you empty your bladder? Do you actually feel like your bladder is empty? We may utilize a bladder scanner. We may have them go to the restroom and then utilize a bladder scanner to see if there is residual urine still in the bladder. You know, are they unable to urinate everything out? We're going to want to pay attention to temperature related to UTI. Abdominal assessment, you know, the bladder could be distended, therefore the abdomen's distended potentially. Like we said, bladder scanner, urinalysis, and then we're going to want to think about those LUTS symptoms versus bladder change symptoms. Okay, you guys want to know those. So we may have to catheterize our person because, again, maybe they're not peeing everything out. There is a Coudet catheter that is made for men with BPH. The tip is skinny and it's curved. So when you put it in, it actually kind of scoops around that inflamed prostate. All right. So if you have to catheterize your guys over 65, I always recommend just start with a Coudet, because if you are sticking a regular Foley catheter up there, you are going to irritate and inflame the area. You can end up with bleeding and damage. Whereas if you just start with a Coudet, and it doesn't matter, it's gonna act the same as a Foley. So if you start with a Coudet, you have much better chance of success of placing that catheter, because once that area becomes inflamed and irritated and we can't place a catheter, they're going to have to go to IR to have IR place that. And that's just, you know, it's a pain. So just consideration with that. For our ticket to class video, we do have a picture of the Coudet catheter, so you can see that. Teaching, you know, watchful waiting, we talked about that. Decreased fluids at night, medication therapy, education, and then following up with the provider related to whatever, whether it's symptoms or status post-TURP, status post that water therapy, and then care related to the surgical and invasive treatments. All right, erectile dysfunction. So according to the National Institute of Health, there are an estimated 30 to 50 million men in the U.S. who suffer from chronic erectile dysfunction, and at least 150 million globally. Incidence increases with age, affecting 52% of male individuals 40 to 70 years of age, and 70% of males over age 70. Most common causes, are you ready for this list? Because it's like everything. So most common causes, you ready? Here we go. CV, smoking, obesity, spinal cord injury, stroke, disease of the neurological system, diabetes, liver, kidney, low levels of testosterone, prostate and or rectal surgery, Peyronie's disease. That's where the penis actually curves because of scar tissue. Adverse effects of meds, psychological issue. By the way, with Peyronie's, I don't think it quite curves like that. Like, I'm having problems. There you go. It's not like that. It's more like to the side or something. All right. Also, psychological issues. So think about stress, right? Substance abuse disorder is implicated in problems of ED in up to 25% of cases. Okay. Diagnosis made on the basis of patient complaint. Careful assessment may reveal causative factors such as diabetes, CV, or low levels of testosterone. Erectile dysfunction is managed according to the cause of the problem. So medication therapy is one of the first forms of med management. You know, that's our Viagra, Cialis, all of those things, right? Now, the biggest thing when we are talking those medications is the risk for hypotension, okay? Don't forget that the penis needs blood flow. So what these meds do is shunt blood to the penis. So if I am shunting blood from somewhere else to the penis, and then I go and get up really quick, or just in general, you're having sex or whatever, you can have episodes of hypotension. So you need to do teaching about this because, first of all, we know all the things related to like orthostatic hypotension. You know, get up slowly, don't move too quick, all of that. But also, they could pass out during sex. Maybe their partner needs to know that this is a thing so that their partner doesn't freak out and think they killed someone, right? I mean, there's things to think about here. So those medications also, they do not work without sexual stimulation, all right? So you're going to take these when you're getting ready, planning on having sex. Sorry, I'm at clinicals and I'm listening to an alert from the ED, but I do not have students in the ED, so we're good to go. So things like Cialis and Viagra, not recommended for anybody taking nitrates or other cardiac issues. Alpha blockers for BPH, because those meds together can cause sudden hypotension. Again, your guy's going to go and pass out on you. Not good. Some other adverse effects can be headaches, facial flushing. It can affect color vision, nasal congestion. The medication chosen to treat an individual is related to the patient's sexual activity and personal choice. So these medications come in pill form and are convenient to use. Also these days there are generics available. So initially, like, stuff was really expensive, like $80 a pill and whatnot, which is, I don't know, that's expensive. I think we can agree on that. But they're generics now, so cost really isn't even a thing anymore. There can be like surgical intervention sort of things. There's vacuum devices that you can use if vacuum devices and whatnot don't work. They can actually do a penile prosthesis. There you go. It's an inflatable tube that's placed in the penis with the inflation bulb in the scrotum. So you pump your penis up is literally what happens. Compressing the bulb inflates the tube, creating an erection. 90% success rate. So, you know, you do what you got to do. Slide 39. So this talks about priapism, all right? This is a real problem. An erection lasting more than 3 hours, priapism, is a rare occurrence with oral medications as well as intracavesimal injections. So that, I didn't put that in the slides. That's a whole other thing, but can occur with any of these treatment options. So priapism is a medical emergency requiring immediate treatment by a physician or in the emergency department so as not to risk permanent impotence. So when we are doing teaching to our guys about the risk of priapism, throw in their risk for permanent impotence. If you are a younger guy and you go and take Viagra or Cialis or something just for fun, and you're thinking an erection for 4 hours sounds awesome, if you throw in there risk for permanent impotence, that's going to change some thinking, okay? Hopefully that young guy talks to somebody about that because it could be a real problem. So RN considerations related to erectile dysfunction. So psychosocial, right? Psychosocial all day long. Assessments, we're going to talk health history. That whole list of risk factors, we're going to want to know if any of that is going on with our person. Also, emotional state. You know, are you stressed out? Also, are you embarrassed? You know, is this something you can talk to your partner about or not? You know, there's, again, psychosocial aspects, right? Actions, meds as ordered, emotional support, you know, non-judgmental, relaxed atmosphere. I know I've seen commercials for like clinics that are male-run clinics for males related to male things. And I kind of think this is, you know, this, you're seeing this more and more, you know, women-run clinics for women related to women things. And I think there is some comfortability in that, right? And, you know, yeah, we're all medical professionals, but some things males are just going to get better related to males, and women are just going to get these things better relating to other women, right? So, you know, those options are out there, which is nice. Teaching, we're going to talk about what factors can be contributing, you know, especially modifiable risk factors, you know, weight, smoking, substances, stuff like that. Stress, I mean, even stress is modifiable. So, and then we're going to talk about the medications. We're going to definitely educate related to do not take ED medications with nitrates because of risk for sudden drop in blood pressure. In general, you can have a sudden drop in blood pressure, and then of course recognizing risk of priapism. Let's see, looking through here, sorry. Just really just being compassionate and non-judgmental, right? We want people to feel comfortable talking to us about these things, because if they don't, outcomes can be serious. All right, talking about prostate cancer now. Prostate cancer is globally one of the most commonly diagnosed cancers in male populations. Patho-wise, it's a slow-growing cancer. There's a lot of discussion about whether or not treating prostate cancer outweighs just letting it do its thing because it's so slow growing. Now, you can have fast growing tumors, don't get me wrong, but in general, prostate cancer is slow growing. Tumors that develop in the prostate tend to develop on the periphery of the gland, which does not obstruct the flow of urine. Hence, they go unnoticed until there is associated pain. Prostate cancer most commonly can metastasize to the lymph nodes, bone, rectum, and bladder. It may be curable when localized, but responds to treatment even when widespread. In cases where the cancer has metastasized to the bone, patients may still experience an extended survival rate. So in the grand scheme of cancers, it's not a horrible cancer. Signs and symptoms, early stage, probably asymptomatic. As it advances, you know, there may be pain, kind of symptoms similar to BPH, basically, maybe trouble urinating or a weak stream of urine. Diagnosis, I love this. This is straight out of the book. That diagnosis of prostate cancer is controversial. This is because they use PSA. PSA is the gold standard for detection of early prostate cancer. But as we talked about, PSA doesn't definitively diagnose cancer. It could be related to BPH. It can be related to other things, right? So that's what makes it controversial. Let's see. So treatment options, you can do radiation, cryotherapy, ablative hormone therapy, chemotherapy. This brachytherapy is where they do radioactive seeds or pellets in the prostate through the perineum. So this targeted type of therapy is used with lots of different types of cancers. So the pellets are actually left in there, okay? And then they gradually lose reactivity over time. So when we are talking prostate cancer though, you need to abstain from sex for 2 weeks, and then you need to wear a condom to protect your partner from radiation exposure. So just know that this targeted pellet therapy, it's used for all types of cancers actually. But when we're talking prostate cancer, abstain from sex for 2 weeks and then wear a condom. Testicular cancer, not very common. When it does happen though, it's usually in younger people. Average age is 33. So that's pretty young to be getting a cancer diagnosis, right? White men, 4 to 5 times more likely than Black or Asian men. Risk factors: smoking, diet, family history, age, HIV, if you have history of cancer in the other testicle, cryptorchidism, Klinefelter syndrome, or Down syndrome. This is really one of the first things where I've seen like chromosome disorders related to a cancer. I thought that was interesting. So that Klinefelter's is an X chromosome disorder, and then of course Down syndrome is a chromosome disorder. So signs and symptoms. It could basically a painless mass in the testes, right? Some patients can complain of pain, swelling, or hardness in the scrotum. There also may be discomfort, like acute testicular pain, dull abdominal pain, dull ache in the scrotum, or a heavy or like firm feeling. The mass may also present with swelling and redness. If there is metastases, then the person may have GI symptoms. You can end up with pain in the lumbar region of the back, gynecomastia, which is breast enlargement. So that would be like, and that's hormone related. Respiratory symptoms: dyspnea, cough, and hemoptysis. Remember, hemoptysis is blood in the sputum. Blood in the sputum, we start thinking TB, but regardless, blood in the sputum is never good, right? Diagnosis: physical assessment, ultrasound, and labs. Treatment depends on the type of tumor. First of all, they can remove the affected testicle. Okay, they can just take that right out of there, including the blood supply to that testicle. So they actually use an abdominal incision to go in and just remove that sucker. Surgery for seminomas may be followed by radiation and or chemo. Non-seminomas that grow more quickly are not responsive to radiation, so treatment for them involves the removal of the affected testicle, including the blood supply, and then removal of the lymph nodes, and then surgery followed by chemo. Okay. Male breast cancer, so rare. 1 in 100,000. Okay. Average age of diagnosis is 60 to 70 years. Non-Hispanic Black men, increased risk. Risk doubles for men who have a first-degree relative with the disease. There are genetic factors related to this. It's the same BRCA gene, actually. Also hormonal imbalances, that Klinefelter syndrome. Obesity, gynecomastia, that's where you have fat tissue under the breast. They actually have gynecomastia is breast development, you know, and usually we don't really expect that in men. Prolonged exposure to heat or radiation, testicular dysfunction, hormone treatments such as estrogen treatment for prostate cancer or estrogen-related meds used in gender transition. Okay. Clinical manifestations similar to those in females, right? You may feel a lump, you may see changes. Diagnosis: physical exam, ultrasound, MRI. You know, if they could do mammography, right? If there's enough breast tissue there. Treatment: male breast cancer treatment correlates with the stage of the cancer diagnosed. So same as for women. Right? Same as for women. Lumpectomy, or breast conserving surgery, or mastectomy. This is again talking about care of our transgender patients. And just remembering that those underlying reproductive organs are present still. Okay, and so we need to take that into consideration and provide that as education. Also as assessment, right? So, but starts with conversation. So RN considerations related to male reproductive cancers. So priority problem: psychosocial, okay? Assessments: risk factors, nutrition, PSA, DRE, digital rectal exam, urinary signs and symptoms. We are going to administer meds as ordered. Wound care if needed, bladder irrigation if needed, stool softeners. You know, remember, anytime somebody has some sort of surgical procedure in that area, we want to think stool softeners because of straining, right? This goes for women too. We don't want to strain because we don't want to pop anything open, basically, right? So teaching is going to be related to disease process, and then, of course, whatever treatments we're using. And then signs and symptoms of infection, because if we're talking cancers and we're using chemo and radiation, our person is at increased risk of infection. This is just a reminder to look in your ATI in your ebook. When you go in ATI and you go to the ebook, you can choose from the chapters, and then on the other side, you can watch videos. So there is a video on continuous bladder irrigation. I think it's like 4 minutes long. So please go in, check out that video. We may watch it in class, but it's not a bad idea to watch it on your own as well. All right, so this concludes Module 7. Thank you, guys.